palliative care in India. So I'm very glad that this topic is taken in front of me. So actually, I'm very blessed to that. So firstly, I would like to invite Miss Joan Marston for this wonderful session. Actually, she is a very good person to guide us through the topic. She lives in South Africa and have a background in nursing and social sciences and have been active in hospice and palliative care for 33 years at local, national and international level. So that's a very long time experience, and I think when I get into know about her, like she is the global ambassador of ICPCN. So that's a very intimidating thing, and I know she had a lot of knowledge to share with us. And on today's session, and on retirement as CEO of International Children's Palliative Care Network in 2017, she established Chase, means palliative care in humanitarian aid situation and emergencies, which is now part of the Global Health Academy of the University of Edinburgh. And also she is on the executive committee of Chase, with special responsibility for advocacy. So I invite Joan ma'am to the session and hope you all have a good experience with her. And if you have any doubts or anything, you can ask her in person or in the chat box. And over to you, ma'am.
Thank you so much, and thank you for the introduction. And hello, everyone. It's really lovely to be back here with you, with Pallium India and everybody. And today we're going to talk about palliative care for children. And of course, because it's such a huge subject, all we can do this morning, well, it's morning for me, afternoon for you, is really touch on certain elements. But it is my absolute passion. I've been working in palliative care, as you know, for going on for 34 years now. And most of it has been spent focusing on palliative care for children. And I have been in India many, many times visiting programs, and there are a lot of similarities between India and South Africa. And so when I see children in India, I see similarities here in South Africa. When I looked at your case study for today, it could have been a child here in Bloemfontein, because another organization I started was Sunflower Children's Hospice. We started 25 years ago, and we care for many, many children with different conditions, and a lot of them have HIV and cancer. So I'm just going to share my screen. Oh, could you allow me to share screen, please?
Share screen, ma'am.
Sorry?
You already have the sharing rights.
I know, but when I opened it, it said host disabled participant screen sharing.
Let me check it once.
Otherwise, if you would share it for me, and you could just move on the, if there's any hiccups with it. Let me try again. No, it still says disabled.
Try it, ma'am.
Okay, one more time. Aha, we have got it. Thank you. Thank you. Let me open up. Here we are. And let me just close this a little bit for now. Right. Why is it not? Here we are. So just to say to you that the principles of palliative care that you've covered in other sessions remain the same. The difference in palliative care for children is the child, because we're dealing with children, of course, from that little newborn. And in fact, children's palliative care begins even before, when a diagnosis has been made of a serious or life-limiting condition in the child, but really up to the adolescent and even into young adulthood at all. And so as the child changes, as the child grows, as we deal with older children, the way we apply the principles is going to differ. And when we're looking at who the child is in palliative care, of course, we think mainly about the patient, and that's who we're going to be talking about mainly today. but we also are dealing with the child who's a sibling. In India or in Africa, we see many children who are caregivers. And of course, that child could be the child of a sick or a parent or a parent who has died. And so we're looking at a broad spectrum of children. But the principles we learn around communication, of course, in dealing with bereavement and dealing with the dying child could apply to all of these different groups. And so we're looking at that child. Normally, if we look at the UNICEF definition of a child, it's 0 to 18 years. Most children's palliative care programs that I see do push to round about 2021, but there are programs that actually push that even further. And in the UK, some of the children that they have are not that small, and they're in their 30s as well, when they have rare conditions that adult palliative care clinicians are not used to looking after, that they stay within what we would call a children's palliative care program. But of course, that child is also someone's son and daughter. And so we're going to be dealing with the parent. They're someone's sister, they're a friend. They're growing and developing. And while we see a number of children who are in palliative care programs or in and out of palliative care programs for symptom management, for support, the way we deal with them is going to change. We might get a child at 3 years old who, again, we see when they're about 10 or 12, when they're an adolescent, and then when they're a young adult. And of course, just as every child is doing, they are becoming. They are growing from that tiny little baby into that little toddler who has developing their own little character and personality and abilities, into that child who might be going to school with their serious condition. And of course, every child is vulnerable. And because they are vulnerable, they are protected in ways that an adult is not always protected. And there we have to take into account, and looking at the case study you're going to have today, it's the external factors. Where and how they live. Are they living in a stable home? Are they living in a home which is quite safe? Or are they living in a shack? Are they living in poverty? Are they living in a humanitarian setting? And who cares for them? Is it an adult who actually has the ability to care for them properly? Or maybe it is a vulnerable adult. Maybe it is an older child. Maybe it's a grandmother who is struggling with her own health problems. So poverty, of course, has a huge impact on what is happening to the child. And what we are seeing now across the world is war and civil unrest. So if we look at a child with a serious illness in Ukraine or in Turkey or Syria at the moment, we can see that there are extra vulnerabilities. But today, while those are really important, we will deal with the basics. And I'd like you all to remember this. Sister Frances Dominica was one of the great pioneers of children's hospice and palliative care. She founded the first hospice unit in the world in 1982. But the lessons that we need to learn from her is that we are the pupils, and the child and the family are the teachers. They are the experts on their condition and how it's affecting them. And every child and every family is a masterclass. So for every child who comes into our lives and that we care for, we are going to learn some lessons, and we are immensely grateful to them. So I'm going to look very briefly at definitions of children's palliative care, pediatric palliative care, what makes it different to adult palliative care, which is going to affect the way we approach providing the care, identifying the children who need palliative care, just examples, how we provide holistic care and end-of-life care. So that's going to include things like pain and symptom management, which we will just touch on because there are a lot of guidelines around that, communication, how we communicate, and how the child communicates with us as well. So just very briefly, definitions. And the essence is always going to be the relief of serious health-related suffering and the improvement of quality of life. But remembering, while we're dealing with health-related suffering, we are also going to be dealing with all those things that impact on them as well. And our interventions in palliative care are in response to the suffering of the child and the family rather than to the disease. And so the disease is important, of course, and we're going to give disease-directed treatment. But actually, when we look at the suffering of the body, mind, and spirit, we are going to respond to that in the best way that we can. So, of course, WHO actually from 1998 had a separate definition for palliative care for children. And it actually, to me, was a better definition than the general definition, because along with the general definition, it spoke about the child's body, mind, and spirit. And we need to remember that we're not giving palliative care unless we're addressing all of those, and of course the family. And it begins when illness is diagnosed and can be given regardless of whether or not a child receives treatment directed at the disease. So we can have a child who's receiving chemotherapy, radiotherapy, surgery, antiretroviral therapy, treatment for their other conditions that's directed at either controlling or at curing the disease. We can give palliative care alongside that. And so we must, again, look at a broad multidisciplinary approach and use community resources. So the other things are similar to the adult palliative care definition. But this to me is the best definition, because Matty, he lived till nearly 14 with a rare form of muscular dystrophy, and he was brilliant. He wrote poetry, he was a philosopher, he called for peace, and this is his definition. He says palliative care for children no longer means helping children to die well, it means helping children to live well. And then when the time is certain, to help them to die gently. Isn't that a beautiful definition? I think we could all use that. And I think that's what we would all love for ourselves as well. To live well as long as possible, and then when the time comes, to die gently. And so, as I said to you, it can begin before birth. We're dealing with neonates up to young adults. And while children's palliative care began as a broad field, where we just looked at everybody and we tried to adapt the principles to everyone, we find within palliative care for children, there are speciality fields developing. And the two main fields developing at present are around neonatal palliative care. And I think if you see the needs of both the baby and the family, when a child, as a little newborn baby, is very ill or dying, you can see how it would be a specialist field up until young adults. And so we need the education. And if we want to specialize in the field, we need specialist education and experience. We need the knowledge and the skills. And we need the ability to be adaptable, because that little neonate who is diagnosed with a genetic condition, we might get into our program at birth, but we might have them for a number of years after that as well. So we have to adapt our approach. Communication skills, of course, the way you talk to that little neonate and their parents is going to be very different from the way you communicate with a 10, 12-year-old adolescent. We need experience. It's not enough to have the head knowledge and the heart knowledge, both are essential, but we also need to have that time working with these children. And I always say, children, what they teach us is a sense of wonder, because every child teaches us something about hope and love and miracles and the beauty of life. And we always provide it within a children's rights framework. So I think that's really important to know. Children's rights are immediate rights. So the child has rights. With adults, we often talk about progressive rights, rights according to what resources you have. But that child has the right to be protected from the very beginning. And so at a global level, we have the UN Convention on the Rights of the Child, which of course India has signed along with most other countries. But within India, you also have your national and regional children's rights and protective legislation. And so if we're going to work in this field, we need to understand ordinary child development. Because to me, it fits firmly into pediatrics, where you need to know what would you expect from a child who is developing normally at, say, 3 months, 3 years, 13 years, and how does the child that we're caring for, how do they fit into that? Because we want this child with a serious illness to develop as well as possible. And how do we measure that unless we know what normal is? We need to also understand that childhood has a culture and it has their own languages as well. And the way they use their forms of expression is going to develop as they develop. And we have to understand that. So we need to broaden our learning. In fact, it's not broadening it. It's going back to when we were children and to remember how we learned and how we understood in our childhood. And of course, it's to recognize that part of palliative care that so often gets sort of left out, or it says, oh, we'll use the chaplain, we'll use the priest, we'll use the minister. It is that which is the spiritual awareness in children and how we provide spiritual care, just on a basic level. So how many children need it? Well, globally, we estimate more than 21 million children would benefit from palliative care. 98% of them live in low and middle income countries where your country and my country squarely fall. And only around 5% receive it across the world. But then in places like the UK, we've got a far higher percentage because they have these programs right across. In many of the developed countries, the higher income countries, most children will at least have some form of access. But we are not doing that great. And I'm going to just briefly mention, in humanitarian crises, children have the same right to palliative care as every other child, but access, of course, diminishes tremendously, and it goes very low down on priorities in humanitarian crises. So what makes a difference? Well, children, because of the way they're growing, the pathophysiology of their illness is going to change. They have unique diagnoses, some which are never seen in adulthood, which is why adult clinicians like to keep even the grown-up children with these diagnoses within the children's programs. Some, and in fact, many of the children we care for are going to live many years. So we need to adapt our treatment. Many have genetic conditions that may affect more than one child. And so you will often get a family that is dealing with multiple deaths of children because they have another child thinking, well, this child's going to be okay. And so Matty Stepanek that I showed you earlier, Matty was one of 4 children in his family that had the same condition. He was the 4th child, and they all died. And his mother developed the adult form of the condition as well. And she is still alive, but and still very active with promoting palliative care for children, but she is in a wheelchair. She needs permanent assistance. So those genetic conditions are very sad, because then you're often dealing with one child who dies, then a couple of years later you deal with another child. The use of medications, the form of medications, we must advocate for pediatric formulations. We use a lot of non-pharmacological interventions. And then, of course, the impact on the family and the community. A child who's seriously ill, a child who dies, has that greater impact, because we believe that everyone should live to adulthood, should live to old age, should live to actually grow and develop and do the things that they want to do. So the impact on other children, and that's not just the siblings, it's their friends, if they go to school, the impact on the schools, and then we look at the impact on the child's development. Some children are affected, it delays their development because of their condition, but then you get other children who, because they are living often in a more adult world where they're going in and out of hospital, dealing with things that other children don't deal with, actually develop emotionally more than the average child of their age. There are a lot of unclear prognoses and unpredictability. There are lots of unknowns because we get children with rare diseases and we actually don't know what is going to happen to them. We have, we try and plan, but then our plan goes haywire. So communication, which we're going to talk about, and bereavement. And causes of death make adult guidelines inappropriate for children. So we need to have pediatric palliative care guidelines. And this is Joan, who's got Pompey's disease. And this is a list of the side effects of his medication, which is nearly as big as he is. He's doing beautifully. He has a mother who's an absolute warrior fighting for children with rare diseases. And then these children, they develop physically, they grow, they develop emotionally, they develop cognitively, which means that not only their medical needs, but their social needs, as well as their changing and growing understanding of disease and death is complex and changes. So the way you're going to talk to the 3-year-old about his condition is going to be very different to the way you talk to the 10-year-old about his condition. And then, of course, reactions to medications. Often these medications, we're not sure about what the dose should be. So we begin with the tiniest dose, and then we go up, but we're not always sure how the child is going to develop. So this is a global picture. I know it's different in India, it's different in South Africa. HIV, the greatest cause of death. Premature births and birth trauma. Neonatal deaths are very, very high in low and middle income countries. They are reducing, and in India, you've done great work in reducing neonatal mortality. Congenital anomalies, which we see so often, injuries and trauma, and just think of the number of children who are going to need palliative care after the trauma of the earthquakes, after the trauma of the war in Ukraine, and cancers. And of course, inequalities within and between countries. So just like in India, we have children who have access to the best health and medical resources. Parents have got the finances, here in Africa as well. But we have many, 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 many children whose parents are poor. They live far away from health services, and it's not that easy. So we have fragile health systems across the world. We have lack of prioritizing palliative care at political level, and we have lack of resources. And then, of course, discrimination in the LGBTQ community, discrimination against women and girls. Look at Iran, what is happening there. Even in our own countries, boys get prioritized. So I think we need to remember all of these things that affect access to palliative care. And so our communication, let's begin with that, because the basis of every single thing that we do, whether it's a clinical intervention, whether it's spiritual or emotional, is the basic thing we do is communicate. And of course, it's going to change. And so the way that Seho here is dealing with this baby and communicating, and there's absolute communication, is through the way she's touching the baby, the way the baby and she are looking at each other, the way that she's talking to the baby, make baby talk, gentle talk, sweet talk, maybe singing, because Seho sings a lot, is going to be very different when that child is a little bit older. And remembering that children, we find spiritual communication often quite difficult, but a child doesn't. They know there's something bigger than they are, because everything is bigger than they are. And however they experience that greater God, whether it is within Hinduism, whether it is within Christianity or Judaism, or whether it is within something outside in nature, it is greater that they can talk to them. From that simple question about, do you mean for the giraffe to look like that, or was it an accident? Which I think is quite a good question, to that really existential question that they're asking God. I love you because you give us what we need to live, but I wish you would tell me why you made it so we have to die. And children want to know about death and dying, and we need to be able to communicate with them about that, as well as about what was school like and what did they learn in mathematics today. We've also got to be able to learn to talk to them when they ask that question, or they give you this letter, or whether they look at you and say, what does it mean to die? They have magical thinking when they're very young. So the belief that unrelated events are causally connected, despite the lack of any logical link between them. So they might believe that they did something wrong that caused their own illness, or the illness or death of another person. So mommy might have shouted at them for doing something, and then something happens to mommy, and mommy gets sick and she dies, and that child believes that because they did something naughty, that caused the illness or the death of their mother. Or they get sick and they think they did something wrong that caused that as well. So we need to remember this magical thinking. And you know, it really links to even to an adult feeling guilty. I did something wrong, and so that must be the reason. And I will never forget a mother that I'm still in contact with. She had 3 daughters. The 10-year-old died in a car accident. She wasn't driving the car. She was in the car, but she wasn't driving it. And it wasn't the driver's fault either. It was a drunken driver. And then her younger daughter got cancer and a brain tumor. And I was nursing her younger daughter. And one day she said to me, I must be the world's most terrible mother. I must have done so many things wrong, because to lose one child means that you have done something bad, that you're bad. But to lose 2 children means that you are really, really a terrible mother. And of course, we know that that's not true. But even in adulthood, we have this magical thinking. And when children express themselves, they might not always express themselves in words. They often express themselves through creativity. And so we need to allow them to draw, to use different colors of paint and crayons, because we know that they will express themselves not only through what they draw, but actually through the colors that they use as well. And just a word of warning, never assume something in art that they give to you. Always ask them. I had a little boy who drew a picture, and it was all very dark, browns and grays and blacks. And so I was quite worried. But when I asked him about it, he said, oh no, but all the other pencils, colored pencils, were broken. These were the only ones that I had. So we always need to ask them the question, why did you draw that picture? Why did you use those colors? It might be that they love the color of brown because they see brown leaves and brown soil and they like nature. So always ask. And then music. Often a child who is loath or reluctant to talk, once you start singing songs, might choose a song or make up a song or make up words to music that will tell you about how they're feeling. I find with children as well, dancing. In Africa, we love to dance, and in India, you love to dance as well, which is wonderful. And so a child can express their emotions, their connections through dance, but also to remember there's another aspect of dealing with children as they grow older and dealing with our adolescents and young people. And that is the aspect that we are very afraid of dealing with, and that is the aspect of sexuality and sensuality. And we like to forget it. We like to think that the children, we don't deal with that part of it, we're dealing with illness. And so allowing them to dance is often an expression of their sensual and sexual feelings, which we need to which we need to deal with as well. And poetry. We use a lot of poetry because we find even little children like to put a poem together. And so we use a lot of poetry with our older children. And we find that we have great expression in poetry as well. And it's something that they create, something that they can leave as a legacy. You know, we put their poetry into books and we can give it to their parents after the child dies. So for some reason, there we go. And I think we can very clearly see the meaning in these two pictures that children have drawn. The one of absolute fear of the clinical, which is why when we're working with children, we should throw away, just put away or hide your stethoscope, take off a white coat, just be in ordinary clothes and work with the child like that, because just what you're wearing can frighten the child. And we can see from this drawing that it's one of our children who is in Sunflower Children's Hospice, and she absolutely loves the Sunflower House. And this is a little girl who nobody was talking to about her granny who was dying. And we don't talk to children because we don't know what to say. But when she drew pictures, I mean, this was just so obvious. She knew her granny was dying. She knew her granny was going to heaven. And she knew that her granny was going to be buried because she showed it with the crosses that go over graves. And when she drew that picture and we could show it to the family, they could then understand, yes, we needed to talk to this child. And then, of course, that form of communication, which is so good for all of us, and that is the importance of play. Children learn, they grow, they develop, they research, they experience, they build relationships through play. One of the best things about working in children's palliative care and pediatric palliative care is that we actually have to relearn how to play. If you've forgotten how to play, then get stuck in again and learn how to play. Because I find often that's when a child will talk to you, is when you're playing with them. When you're sitting on the floor, when you're playing with a motor car, when you're drawing a picture, or when you're playing with sand, and you're not talking about their illness, you're not talking about their parents' illness at all, is when they'll suddenly ask a question and say, you know, am I going to get better? Or have I got to go to hospital again? Is that going to make me better? So play with the child, because that gives them the opportunity to feel that you're at their level and that you will understand what they're going to say, and they will then find it easy to talk to you. I say play is often a sacred space. And Albert Einstein, of course, one of the greatest brains who ever lived, he said, play is the highest form of research. And you can see 3 of our little ones, and I do use pictures from our hospice because I have the relevant permission to use these pictures. These little children have all since died, but the family have again given me permission because we keep in touch with the children. And to say to you, that wall you see behind you is our sunflower wall of remembrance. And when a child dies, we put their name into a sunflower. And when they're old enough, they actually will show you which sunflower they want their name in. Right. And then when we're dealing with children who are sick, wherever they are, whether they're in our homes, whether they're in our programs, whether they are like this child in Syria who are dealing with a humanitarian setting, what we need to do is keep as much normality as possible, because it's the normality at the end of the day that will help children to cope. And Stefan Friedrichsdorf, who is one of the great leaders in pediatric pain, when he has older children who have complex pain, the first thing he says to the parents is send them back to school. If they can go to school, send them to school. It helps them to feel like normal children. And it's that normality that helps them to cope with their illness. So if we look at pain in children, again, as you've learned with adults, it's not just physical. It's psychological, it's social, it's cultural, it's spiritual. It affects every part of the child's being, just as it affects every part of our being as well. And when we're dealing with pain in children, we tend, one of the things that being an elder in palliative care and having been in it for so long, I have seen how it's gone from, we did simple things in the beginning because we actually didn't have the knowledge, we didn't have the research to help us to do the more complex things. But it's become quite a complicated field. But when we're working in low and middle income countries where resources are limited, I think this is such an important message that Liz Molyneux said. Do things simply and do them well. So if we're going to deal with pain management, let's learn a few simple interventions. If we're using a pain tool, use a simple tool that you can easily understand and the child can easily understand. Make yourself competent in a few areas because that will build your confidence as well to do things that are more complex. And always, just as we do with adults, we need to use a pain assessment tool so we can get a baseline and we can see their progress. And we always assess a child when they're resting and if they are active, when they're active as well. And we use simple tools, whichever the ones that you feel happy about using. There are fantastic guidelines. There's a number of different tools and tools that you can use, from that new little neonate, the NIPS tool, to the FLAC tool, which helps you to assess a child who is nonverbal, to the more adult type tools as well. And there's a very, very good paper that came out from Stefan Friedrichsdorf and Andrea Postia, and they talk about how pharmacology alone, medication alone, in many children is not sufficient to provide excellent analgesia without oversedation. And Stefan, every year, he runs a masterclass on pediatric pain and palliative care. And there are always a couple of bursaries as well for people from low and middle income countries to attend these masterclasses. And if any of you are interested in this field, I really would suggest that you try and get to one of these masterclasses. They're always in the US. He is in San Francisco, but he is always very open to helping people from other countries as well. And so he looks at multimodal analgesia. So it's not, yes, using the medication, because medication is important, but how you can reduce the medication that is used by approaching it. And he uses hypnosis, distraction, making the child live in as normal a life as possible. Physiotherapy comes into it, non-pharmacological actions like reflexology, aromatherapy, and all of those different kinds of interventions with children. And he always brings in clowns. So we use clowns in hospital, and he suggests clowns as well. And so we'll be using the basic medications as you do with adults, but you will actually then use it in dosages that are linked to the child's size, to the child's weight, and to where the child is in their development. The adjuvant analgesia that you can use, very similar, as you see, to adults, just the dosages that differ. And then he talks about rehabilitation, about psychotherapy, cognitive behavioral therapy, skill-based learning, helping these children to develop a competence in something so that they can actually feel that they have control. Because just like adults, if a child feels they're losing control, they're going to get depressed, their pain is going to get worse. If you can give them something that they can control, then they are going to be able to cope better with their illness. Spirituality, which includes providing access to whatever you call them, whether it's a chaplain or whether it is a spiritual care provider, and then the integrative and non-pharmacological therapies, which is breathing, bubble blowing, self-hypnosis, progressive muscle relaxation, things that we can do, even if you're not a clinician, that you can help with. I had a child with really, really, really serious pain at the end of life. And an aromatherapist came in and she gave her full body aromatherapy in the morning and in the evening. And that reduced her medication use tremendously. And so it also reduced the use that she needed of morphine, which reduced her constipation, which reduced her feeling of not being in control. So you can see how these non-pharmacological therapies are really very, very important. And technology. Children love using technology, don't they? So if you can use an app, if you can use a computer, if you can help them to harness the power of technology, and the digital innovation is something that UNICEF has got a department on. So if we can use technology, that's wonderful. It keeps them connected as well, through connecting with their friends, through connecting with their health team. We are seeing another challenge that you might see as that children with chronic illnesses from poor families are actually managing their condition to get them into hospital more often, because in hospital, of course, the staff really spoil them and they are given things that their family cannot afford. So we need to be on the lookout for this as well. So at the end of life, and I'm sorry, I know that we're going through this very quickly, but there is time for question and answer, of course, at the end. And because this is such a huge field, again, as I said in the beginning, that we need to just touch on a few things. But I think dealing with the dying child is important. And this is a very, very good paper that came out. And I would encourage those of you who can access, and it's easily accessed. It's Dr. Pohing Chong from Singapore. It was his PhD study, and it really was a very good one. And he talks about these are the things that are important at the end of life. So the letting go is the child being able to let go of things that are important, but it's also the family, the parents being able to let go of the child. It's acknowledging the child's voice. So where the child can be part of decision-making, where they can say what they want, where they want to be, who they want around them, what they want to do, we actually need to listen to that voice. It's so important. It's allowing the child and the family to make closure. So it might be making a memory book, a memory box. It might mean the child giving away favorite toys to their best friends, to their siblings. It might be something that the child really wants to do before they die. So we need to ask them that question. What do they still really, really want to do? And all of these things are allowing the child to still be in control. Because that, if they're not in control, it's going to lead to a lot of anger, and they're not going to comply to whatever we want to do because they want to make the decisions. So again, let's see what control we can give to that slightly older child. Of course, when it's a baby, we're going to be in control. And we never take away that miracle of hope, that something is going to make them feel better, that something is going to help them control their symptoms, that something is going to help the parents to cope with what is happening, or whoever is looking after that child. And the other thing that Pohing also highlighted is that, of course, depending on so many different factors that we have talked about, it's going to be levels of understanding, it's going to be their age, is there going to be different levels of awareness of what is happening, and we need to be reactive to each of those different levels. We need to have systems and processes in place. So what policies and procedures and systems do we have in place for the child at the end of life? And of course, the main thing then is how do we reduce suffering and allow as much normality as possible? Now, I find there are lots of things that are cultural and that are dependent on whether the child comes from a high income place or from a low income place. So where we are, and we deal with a lot of children, we have a big home-based care program, and we have a unit, Sunflower House, where children who can't be cared for at home are cared for. And if you go into a children's hospice in a high income country, you're going to find one child in a room with lots of things around them. If you come into our hospice, you'll see children are together. In every room has a number of children, because in African culture, being alone itself is a punishment. And so that child wants to live till the end of their life and even die in a place where they feel there are people around them. So normality is going to change depending on the context. And when we can't stop the dying process, we can give them all the comfort in the world. And you can see with our little Lena, how just being with our, one of our first chaplains, how just being with him gave her comfort. And also it comforted the chaplain, knowing that he was giving comfort. So when we give that comfort to the child, it gives comfort back to ourselves as well. And we need to have an advanced care plan in place. What are we going to do? What are we not going to do? Where does the child want to be? It's not always possible, we know that. Especially very poor children, the family often just cannot look after that child at home, no matter what we do. They might live in the shack. And who does the child want with them? That's important as well. Is it possible to have that person with them? So we need to identify who the important people are in that child's care, from the clinical team, the multidisciplinary team, but also from the team of their family and their community, and what is needed. And what resources we have as well that we can use for this particular child. And to remember the bereavement support that begins before the child dies for the dying child, as well as bereavement support for the family. Because we can't leave the child alone. I think that's one thing I want you to take out of this, is a child needs to be accompanied along that journey. They are facing the most overwhelming things happening in their life. And as adults, we would be hard pressed to deal with it. And if we leave them alone to deal with it, it will overwhelm them. But if we can be a constant caring presence, we'll make sure there is someone who is a constant caring presence in that child's life. It's going to make life much easier for them. And so we talk about spiritual assessment and care. That part of palliative care that is usually across the world done very badly. And it's mainly because people don't understand spirituality and they link it to religion. And of course, religion is very important. And we practice our spirituality often through our religious rituals. But spirituality actually is about meaning and purpose. It's about transcendence, which means we feel part of something bigger than we are. It's about being connected to ourselves, how we feel and experience ourselves, to other people, to nature. And it's about mystery and paradox. So we know that within spirituality, there's an element that is mystery. And it always contains, how do we engender hope in our spiritual care of the children that we care for? And that hope changes, as it always does in palliative care, from hope for a cure, to hope to feeling okay and not having pain, to hope for many, for something after death. And there's a very good definition. It's a consensus definition. It had people from all different belief systems who took part in developing it. And here it acknowledges that spirituality, it grows and it changes, it's dynamic and it's intrinsic. It's part of every single human being. It's that part that is part of us when we're born, and that is part of us when we die. And for many of us, it's that part of us that continues. And it's the way that we look, as I've said, for meaning and purpose. And we express it through beliefs, through values, through traditions and practices. And with children, it's helping to show them that their life has meaning. It might be short, but it has meaning. It's helping them to connect. This is another one of our chaplains. And as you can see, it's not about kneeling down and saying prayers or telling Bible stories. It's about making each and every child feel that they're important, that they're connected. And you can see the connection with Father Joshua to each other and to Father Josh, and connecting with joy. It's making them happy. It's helping them to interact with others. It's taking them out into nature. Let them feel the rain. Let them feel the wind. Let them see the light in the trees. Let them touch the puppy or touch the donkey. But it's also supporting rituals that are important to them and the family, and prayer. And that's allowing them, it's giving them a space to also ask the questions that are important. What is it? Why do people have to die? What does it mean to be dead? How would you answer that question if these little children, we were in the garden and these 3 little ones came up to me, and it was after the death of another child who was in the children's hospice. And they asked me, what does it mean to be dead? How do we answer that question? Because it's important to them. They wanted to know. So there are many responses, and there's no one right answer to this. You know, I always first find out, why do you ask me that? It could be that they found a dead frog in the garden and they want to know about the dead frog. But with these children, it was about the little girl who was dead. And so I asked them, why are you asking that question? It might be that they're frightened of being dead. And so I always ask them back if they can talk. What do you think? What do you think it means? What made you ask that question? What have you been told? And after that, and they're still asking me the question, I'll say, well, I don't know from experience because it's never happened to me, but this is what I think, this is what I believe. And children actually, they're usually very open to accepting that. And one of the things that children are afraid of, adults, all of us, we're afraid of being forgotten. And that was why we built we painted our sunflower wall, where every child knows that they will always be remembered because their name is there, and every year we remember every child. And so I encourage you in this field. There are wonderful resources that the WHO ones are online. The ICPCN has brilliant e-learning courses that are free on icpcn.org. And the first ones in Hindi, in fact, have just come out. There is, for those of you who are more in the academic field, then there's a brand new, just over a year, new first journal, especially for pediatric palliative care, PalliaPed. And you can contribute to that journal online as well. And so I want to say to you after this, in our hearts, we know that palliative care for children is essential. It's not just important. If we want our children, all children, to have the right to live as well as possible and for as long as possible, then palliative care must be integrated into every healthcare system. It must be part of primary healthcare. It must be available at primary, secondary, and tertiary level. It must be available in humanitarian crises, but it's not. And so why do we allow the present situation? Because we are not advocating loudly enough. And we all must be advocates. We who are adults are lucky enough to have grown to adulthood. I, as an older person, am so fortunate to have lived so many years. And so I have a responsibility to advocate for children. And what we want to do is provide the quiet miracle of a normal life. Because what is normal? So if we can do that, even for a child who is seriously ill, who has a life-limiting condition, who may only be living for a few hours, a few days, a few months, a few years, or even many years, what can we do as palliative care practitioners to give them that quiet miracle of a normal life? So thank you for listening to me. These are the groups that I'm linked to: PalChase, Patch, which is the South African National Network, and of course our own Sunflower Children's Hospice. And I'm very happy to engage in discussion or answer questions that you may have.
Thank you so much, ma'am, actually. So it was a very wonderful session. Meaning, like, I've been practicing with palliative care, like in children in palliative care with the setting. So I do have so much complications, like what you mentioned earlier. So we'll be going to that. Before that, I think we have a case presentation. So we will go with the case presentation. After that, we will be checking out their questions and queries. So next is case presentation by Isha Vista.
Can we ask a question, or is it after the presentation?
After the case presentation, we can ask.
All right.
Will you be sharing the slide for me?
Yeah, can you see it? We have shared it.
Yeah, okay. So I'll be doing the case presentation today. I work in a children's hospital. I'm from Nepal. It's called Kanti Children's Hospital. And the patient that I've chosen was admitted in the oncology ward there. So you can change the slide. Okay, so name of the patient is patient X. She's 10 years old, a female, diagnosed with acute myeloid leukemia. She's from Dang. It's a rural place in Nepal. And she's still currently studying in class 3. So the patient initially came to the hospital with fever for 7 days, poor appetite for 2 weeks, and lethargy for 2 weeks. They'd gone to their local health practitioner and they were referred to come to Kathmandu. Then they had hemostasis 4 days back, pallor was present, bone marrow aspiration and biopsy confirmed the diagnosis, and chemotherapy was started. For the insight, the patient didn't know about the illness. She said that she felt well. She thought that she will get well in the future, and she had no idea about palliative care. The parents who came with the patient, the father had gone back to the village for something. I interacted with the mother, and the mother knew that it was she had blood cancer. The prognosis, she was not sure. She said she couldn't think, and she was uncertain of the survival of the child. And she also didn't have any idea about palliative care. I think the father would have known a little bit more, according to the mother, but I didn't get a chance to interact with him. Next. So I don't know the ages of the family members, but she had a younger sister. I think the mother's age must have been around 30 years old, but that's just an assumption and I might be wrong. Next. So in the eco map, they were very close to the maternal home. The patient had decent, good relationship with grandparents, paternal uncle, school, friends, but a little distant relationship with the villagers, their relatives, and neighbors. According to them, like even their neighbors and relatives would earlier call them, once the child had started having issues and she was diagnosed with cancer, they stopped calling and they wouldn't receive their calls. And the mother thought that it's because they would ask for help and they'd ask for money and they wouldn't really want to engage with the family. With friends, they were not very sure, but some of the friends said that they'll try to get money for them. And they were in contact with the child's school, and the child's school, according to the mother, they said that the child's school would be helpful to the child, whatever was needed. And the grandparents and paternal uncle recently started a job and maybe he'd be able to help them. Next, please. So the socioeconomic back overview. Father is the breadwinner of the family. He worked as a migrant worker in Saudi Arabia for 4 years as a cook. He came back to Nepal 4 years back and has been unemployed since. He had planned to go abroad and work this year, but made changes to his plans after his daughter was diagnosed with AML. In the past, the child's grandfather and uncle spent a lot of money drinking and gambling and did not help this family or share the family money with them. They asked for money. They had lent to others, borrowed money from their maternal aunt and a friend, which amounted to total 1,05,000 rupees. There's history of substance abuse in uncle and grandfather. I'm not sure if it's in dependency level though. Uncle had begun working and may help them financially. I'm not able to read the last line. Wait, I can open my. Okay, uncle has helped them financially. 1 second. Most of the relatives do not keep in touch with the family after they were informed that the daughter has cancer. So we'll do that. Next, psychological overview. After admission and investigations were being conducted for cancer, the child's mother was not able to eat or sleep. After the diagnosis was confirmed, she did not feel like talking to anyone. She was irritable, fearful, and had suicidal thoughts. At the time of interviewing, she began to cry. She reported that she had a headache whenever she was interacting with others, occasional difficulties sleeping, and had never negative thoughts that her child may not make it, especially when she would refuse to eat. In the phone call, the youngest sister told their mom to return back home since patient X was going to die anyway. According to the mother doubts that it's the grandparents who told the younger daughter that their daughter was going to die. The patient did not have any anxiety or depressive symptoms. She missed going to school and studying with her friends. Next, please. So the physical symptoms, in total pain, the physical symptoms was fever, loss of appetite, and lethargy all the time, at the time of admission. No symptom at the time of interviewing. The patient felt well. Psychologically, no symptoms at the time of interviewing. Socioeconomic symptoms was she missed going to school and studying. And spirituality, I was not sure how to ask. I asked her, again, I made the mistake of confusing it with religion. So I asked her on what she thought of God, and she was not very sure. So then I didn't know what else to ask. I tried to go a little bit into existence and stuff like that, but then I was not very comfortable and she was also confused. I think I didn't do a very good job then. Next. So points of discussion would, according to me, is how to disclose it to the patient and how do you ask about spirituality in children? How do you ask the children? Thank you.
Thank you, Isha. So, yeah, ma'am, you can go like with the case presentation, like if you have anything to discuss. Like,
Yes,
to-
thank you.
Yeah.
Thank you so much for this presentation. I think it's something that this child could have been in South Africa as well, the whole social context and everything. So I say there are just so many similarities. So, I mean, this is an older child.
10 years old.
And so if we're looking at disclosure, it's finding out how much really she knows, is building that relationship. And I find with children, it's not as simple as with an adult. If it was me who was the patient and I've been to the doctor, he would say to me, how much do you know about your condition? And sometimes and I would speak about it quite openly. But I think with a child, often because they've got so many confused thoughts in their head, is that they don't open up to you. So you need a bit of time to build that relationship. And I know often with acute leukemia, there isn't a lot of time. But asking them, what do you know about your illness? Do you know what's the name of your illness and what it does to your body? And how are you feeling about it? So it is actually to get them to tell you as much as possible. The second thing is, because she is, sorry?
She told me she had fever, that's why she was admitted. She didn't know.
That she didn't know about. So nobody had actually, but I think, she's old enough to be told. And one's got to do it. It's really important.
Yeah, and like the way her mom was responding, I'm sure she knows that there's something wrong, but she doesn't know what's wrong because she felt very well. She didn't have any issues with her body at that time. But then her mom was, like, when I met her, she was already better. But then she told me that initially when she found out, she wanted to actually kill herself. And then she'd cry a lot and she'd get irritated with everybody. So I'm sure she picked on those stuff, but then she really didn't know. Nobody told her, so.
Yeah. And I think this is one of the big problems, because we don't talk and tell them and give them the information because we don't know what to say. We actually feel uncomfortable talking to them. And I think when a child is, she's an older child, that she's old enough to understand a lot. So I think having somebody to gently explain to her what her illness is and what she's got to watch out for, and not necessarily give the worst case scenario at all, but explain about the treatment if she's having treatment. And using language that she understands. I don't know what language speaker she was, having someone who speaks her language, who can explain it to her.
She's spoken Nepali, so all of us would be equipped to do that.
Yeah, to do that, yes. But it's also how you do it as well. Where you do it. If you stand at the side of the bed and do it, well, we know that's totally the wrong way to do it. Is to be sitting with her, and find out first what she knows, and then say, well, I want to explain to you about the condition that you have, and this is what we see with this condition. And do you have any questions? And think about it, and I'll come back to you tomorrow and we'll talk some more, if you have the time to do it. I know in a hospital you don't always have that busy time. And say to her, is there someone that you like to talk to when you're worried? Because that's going into the spiritual domain as well. We tend to think of spirituality as being this complex, difficult, over there type of thing. But you were talking about not knowing what questions to ask. It's about, who's special to you? What are the things that make life good for you? What do you enjoy doing in life? What gives you, is there somebody that you like to talk to when you're worried about something? Finding out that as well. But I think, from a clinical point of view, it's important to give her information at a level that she can understand. And let her ask. And yes, of course she's going to be depressed, and she's going to be angry, and she's going to be irritable. These are all, she's losing her health. She's losing what she thought the future was going to be. She was just going to continue going to school and seeing her friends and doing all the things. And now you've said to something, it's something that's interrupted normality. And yes, we know that all those emotions that she's showing are emotions of loss.
Kubler-Ross.
Kubler-Ross, absolutely. And remembering that Kubler-Ross didn't just talk about 5 emotions. She talked in her first book, she spoke about 13 emotions, and she spoke about hope having to be the overarching. So at this time, you want to give her that hope. But if you look at it, it's anger, isn't it? What causes irritability? It's anger. It's depression, suicidal. You know, it's even just the five stages that everybody knows about with Elizabeth Kubler-Ross. But I say she was much more than that. She was really a life and living lady. She wasn't death and dying. It was how do you live best, and that unconditional love is actually what it's all about. At the end of the day, that was her message. But I think she's, and you expect her to have those feelings instead of, you know, thinking, it's saying to her, it's normal to feel like that. It's okay that you're angry. It's okay that you're sad. It's okay that you're irritated. You know, to recognize all the losses that she's experiencing. And then from the spiritual, you know, with spirituality, with an adult who perhaps, you usually would start with finding out if they have a religious framework. There's no absolute definition between the two, because we often express our spirituality through our religious beliefs and rituals. To find out, does she belong to a certain religious group? Because that might affect the way you're going to approach this as well. So
I think she's Hindu, but I asked her, does she believe in God? She didn't give me a definite answer. So that's why I was stuck. Otherwise, I could have expanded on what she said. But she was not sure.
And maybe she's not sure. And maybe and you can ask, do you believe there's something bigger than you are? You know, something greater than you are. Because for some people it's nature. Some people it's the earth. And not a God figure. For myself as a Christian, I would talk about God. And if I had a child who came from a Christian background, then it would make things much easier, because that's something we have in common. But it's not only asking about God, is you know, what is greater than you are? What is bigger than you are? Could be family. What makes you happy in life? What are the things that really make you feel good about yourself? Those are spiritual questions. What is the most important thing in your life? Could be going to school. That's what gives her life meaning. And how do you then develop an interaction? It could be the school sending her messages. It could be the teacher coming to see her. You want to build that connection. How does she connect with others? But now she's disconnected because she's taken out of the place that she knows, the family that she knows, the friends that she knows, the routine things that she does. So we've got to disconnect. How do we build those connections? And that's what spirituality is about. It's about meaning and purpose and connections. And if we're going to give spiritual care, it's how do we build connections? You know, are there other children in the hospital she can talk to? Are there other kids who enjoy doing the same things that she enjoys doing? Can you take her outside into the fresh air? Because it's important that we connect with nature as well. Those are all spiritual care activities. And then are there religious rituals related to her Hindu belief that are important to her? Lighting a candle, whatever, yeah. It's hard though.
Yeah. Thank you.
Yeah, thank you, Isha. So I'll just intervene in that topic, the class means and the case presentation. Like, how long have you been helping that children? Could you tell me the time frame?
The questions for me?
Yes, Isha.
I went to the oncology ward for this case.
Okay.
We have a license. If there is a problem, then we go.
Yeah, like how long have you been seeing that in this case?
I saw her only one session.
Okay, clear. So I think I have 2 points to make clear. Like in this case of discussion, we have pointed out like disclosure of patient and spirituality in children. And just going through that case, I found like my suggestion would be like there is a mentioning of the younger children's problems. Like, why are you taking care of that elder child, and
Mhm.
she will be she'll not get very far away from that disease. So the mother should have to come to home. So she is in a despair, like she needs care too. So that's the thing we have to consider, like for a discussion or for the future purpose. And the second thing will be like they have so much family problems, and they don't even know about the exact prognosis, like what is going to happen next. So there is an education needed for that, I think.
No, so
Yeah.
every patient that comes, they are psychoeducated,
Yeah.
but it's also how much you can grasp. Because at the time when the mother was, so that's why I said I think the father knows more, because the child's mom said that the father is not here right now. I think he understands more. I know it's blood cancer, and so many things were in her mind that even if she was educated, which she was, every parent is educated about the child's illness. I think she wasn't able to grasp because hearing the diagnosis itself was very difficult for her. And after that, I think it was very difficult for her to grasp. So educated they are, but it's how much she was able to understand at that time. And when I'd met her, they weren't there for very long. It was a new child whom even like nurses also didn't know so much about her. She was relatively new.
Okay. Okay. So what I was saying about this, in this 10 years of time, she haven't had any kind of illness or any kind of symptoms or anything. All of a sudden, this came out. She needs some coping mechanisms. Like she is well educated, we know that. But when something hits you hard, then you will be stuck. But so that's the thing that's happening with the mother. So we have to like first. I know that it's an important case, and we have to tell the kid like what your ma'am said. We have to educate that kid too. Like this is going to happen, or with various sessions only. It will not happen in the very first session. I know that. So we have to consider the younger child, and we have to just go through a detailed session with the mother and the family too. Then only we can get more details, and we will have a proper plan for that. It's my suggestion only. Okay.
Thank you.
So rather than the case presentation, if you have any, I think Ravikant or anyone asked some questions. If you have anything, you can just ask right now.
Good evening, Joan Marston. So it's really wonderful to have such a comprehensive and detailed session on children palliative care, because something which is very much ignored. Because when we consider, especially the palliative care itself, India is a growing field, and moreover, subspecializing into children is something very niche area, and it has a lot of potential benefits to address. The one question I have, John, is that how can we handle, because when the parents are in a denial stage, when parent itself lacks education, when the parents itself lack awareness, because even though we want to help the child, and sometimes what I observe is that recently I have seen a non-epileptic seizures case of a adolescent. The problem is that the parents are not willing to come forward and bring them to the sessions. So in such cases, because when it comes to palliative care, that is much more challenging. The nuances of the system.
Yeah.
So something which is
Yeah, that's a really hard one, because we work with a team in the community as well, and so we often find by providing support in the home that helps the parents and helps us get the adolescent. And what your question is a really important one, because it brings ethical issues into it as well, because we know that the UN Convention, and in fact all national conventions, say that in every situation regarding a child, the best interest of the child has to be your primary consideration. And yet you don't want to cause a disconnect between the child and the family. So I always say to people, you know, if the family don't understand, the best we can do is just support them and help them to at least bring the child for the sessions. Is this a child who needs to have treatment coming to the sessions? We have a big problem with the children not coming to clinics to get their treatment. And the only way we deal with it is by working in the community and going into the homes and looking at what are the issues that prevent this family understanding. Sometimes it's intellectual. You know, they honestly don't have the intellect.
Absolutely.
It's nothing to do with poverty or anything. They truly don't have the intellect. Sometimes it might be a belief system, is that my child doesn't need treatment. There's going to be a miracle, or he's going to have some other kind of treatment. Sometimes that denial that you talk about is, I can't cope with this. I can't cope with it. I'm dealing with poverty. I haven't got a job. We haven't got enough food. Now this is happening and I'm protecting myself by denying it. So it's looking deeper into why the parents are denying, because they're not only denying to themselves, they're denying this child a chance of treatment. And as I said,
the courses you are mentioning regarding the palliative care, is that which is freely available?
On the ICPCN website, there is an e-learning section. They have a number, I think they've got about 10 different courses. And the first, as I say, the first Hindi course has just come out, but all the courses are in English. And then they have different languages depending on who they've got to do translations. But they cover all the basics of.
Can you don't mind? Can you just spell that thing because I'm? It is. Can you type or something if you don't mind? I think.
ICPCN.org. I'm just putting it into the chat. All right.
Yeah, please.
The ICPCN. It's the International Children's Palliative Care Network. And they have a very good selection of freely available online courses on children's palliative care. Which is,
I look forward to have these protocols, whatever you people are doing there, and at some point in India to, incorporating into the mainstream of medicine and incorporating these protocols as mandatory. And if that stage should come in the near future for the betterment of all.
Yes.
So I look forward to that stage.
But that's
Thank you very much for such an insightful talk. Yes, all of us have to work because the Pallium India is taking such initiatives.
Absolutely.
Thank you very much.
Yeah.
Thank you so much, madam.
We all have to take every opportunity of saying, don't forget about the children. Because often, yes, we're going to do this and that and appoint people, and you find it's all adult focused. So we just, every time I see it's been missed out, I just either send a letter, put up my hand, say, what about the children? Because remember, these children can't fight for themselves because most of them are too small. The parents are exhausted just looking after the child and surviving. So we have to be their voice.
I was looking forward for this course because I work in a children's hospital. So all my patients are children. And then except this class is a very adult-centric course itself.
Yeah.
So I was like, okay, something for me, kind of, I don't know. I was thinking.
And actually in Nepal at the moment, in Pokhara, because I'm also with the Elizabeth Kubler-Ross Foundation, there is a course going on.
Course, I don't know, but I know in Pokhara also something palliative care initiatives have been taken.
Yes, and there's a 2-day course tomorrow and the next day. I'm doing a Zoom. I'm supposed to be there, but my passport didn't come through. There's a 2-day course on pediatric palliative care. Yeah.
Who's organizing it?
Amrita, I'm trying to think, Dr. Amrita. I'm not sure which group she's with. I'll find out, and if I can send the information to Pallium. Or Isha, I've got you. I think I've got your email. I've got your
Yeah,
email.
so if the course is, can we join that course? Is it possible to be part of?
I don't know if they're going to do a Zoom, but what I can do is send through to Pallium India so that they can let you know, because tomorrow there's an International Children's Palliative Care Network webinar. So every month the ICPCN holds a webinar, and on that webinar it covers different aspects of children's palliative care. It's always open access, free access. If you go into icpcn.org, which I've given you in the chat, you will find information on the webinars, and they have recordings of previous webinars as well. And then they have various textbooks that are freely available to download. The one is focused on Africa, but a lot of what happens in India and Africa is very similar, and the principles are the same. It doesn't matter whether you're doing it in America or in India, the principles are the same. There are 3 textbooks you can download that have got a lot on, that are based on pediatric palliative care. So I would really recommend you go into the ICPCN website and you will see all these resources.
Okay, so any more questions from anyone regarding the session? So I think there is no further questions from everyone. The topic was actually what Isha said, like during the whole sessions, we haven't had any children related, like palliative care, children palliative care. Like, so this is the first time I'm also attending it. So it's a very informative session. So we had gone through a lot of points, and the supreme part is the spirituality part. So we need to learn a lot about that. Before that, we have to do so much groundwork. So I think we will get enough suggestions and guidance from you on the coming weeks and all. So if anyone has any questions or queries, just text us or put it in the box or with the share with the feedback form also. Okay. So thank you so much, yeah, ma'am, and I hope you are doing very well, and wish you all the very best. Okay.
Thank you. Thank you. It's been lovely being with you, and I'm always available to answer questions or point you to somebody who can answer the question. So thank you very much and enjoy the whole course.
Yeah. Thank you so much.
Thank you so much, ma'am, for joining us today. Thank you all. I will see you on next meeting.
Thank you.